Alfred BUXTON from Beth Israel Deaconess Medical Center and Harvard Medical School in Boston in the USA. And I discussed the area of sudden cardiac death in patients with coronary disease. This is the area that has probably been studied the most. We have the most data in this area, and yet our current guidelines for reducing the risk of sudden cardiac death leave much to be desired. They are probably outdated, having been based on a number of trials that were conducted 15 or more years ago. They are based in trials that did not have physiologic basis, but rather were based on identifying populations of patients that had relatively high risk for mortality, but not necessarily specific arrhythmic risk. We have performed, along with a number of other groups, multivariable analyses in an attempt to identify patients at high versus low likelihood of benefiting from implantable defibrillators. And we and other groups have identified multiple variables. Models have been created, but they've not been tested prospectively. And so one of the areas in which we hope to move the science of primary prevention of sudden death forward is to test in a randomized controlled trial the utility of patients with multiple risk factors, whether or not they actually will benefit from an implantable defibrillator. The second area in which we propose moving forward is to integrate the relationship of left ventricular geometric remodeling with the genesis of arrhythmia, and markers for geometry from the echocardiogram or cardiac MR may prove useful in identifying patients that are increased risk for having ventricular tachycardia or ventricular fibrillation. These two remain to be tested prospectively.